Welcome to meeting number 33 of the House of Commons Standing Committee on the Status of Women. Pursuant to Standing Order 108.2 and the motion adopted on Tuesday, February the 1st, the committee will resume its study of the mental health of young women and girls. Today's meeting is taking place in hybrid format, pursuant to the House Order of June the 23rd, 2022. Members are attending in person in the room and remotely using the Zoom application. I would like to make a few comments for the benefits of the witnesses and the members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you are not speaking. Interpretation for those on Zoom, you have your choice at the bottom of the screen of either floor, English, or French. And for those in the room, I'm just going to remind you of your earpiece, and on your set, it will show you the choice of, once again, floor, English, or French as well. For members in the room, if you wish to please speak, please raise your hand. And for members on Zoom, please use the raise hand function. The clerk and I will manage the speaking order as we best can, and we appreciate your patience. We are already halfway through the study on the mental health of young women and girls. And it was previously agreed that the committee undertake its fourth study, a study on human trafficking of women and girls and gender diverse individuals for sexual exploitation in Canada. So we're halfway through this study, and we're now preparing for our fourth study that we're going to be doing. That is on the human trafficking of women, girls, and gender diverse individuals. And we're asking that if you could send in your witness list, if everybody could send in a prioritized witness list. The date for that is Friday, October the 28th. I got Kyle's nod there, so it looks like everybody in the room knows by October 28th if everybody could get these in. Just a reminder, this is a reminder to everybody. We are welcoming our witnesses, and I would like to provide the trigger warning. This will be a difficult study. We'll be discussing experiences related to mental health. This may be triggering to the viewers, members, or staff within similar experiences. If you feel you are distressed, please advise the clerk. I would now like to welcome our witnesses here for us today. We have from Abrar Trauma and Mental Health Services, Abrar Mekmekia. Meshmeshia. Oh, and it's French. Meshmeshia. Fantastic. Yes, go ahead.
Just, Madame la Présidente,
Madam Chair, the witnesses that are online, did I understand correctly that they all did their sound tests so that interpreters can hear them?
Yes. Okay, we're in good shape? Okay, excellent. Everybody's good? Fantastic. So thank you very much. So, Mishmisha. I'm going to get this by the end, I promise you. We also have here today, as an individual, Tracy O. Afifi, who is a professor. From the BC Children's Hospital, we have Jennifer Colo, psychologist, provincial specializing eating disorders program. And from the Canadian Mental Health Association National, we have Sarah Cannell, who is the National Director and Public Policy. And from Mental Health Commission of Canada, we have Michelle Rodrigo, Rodrigue, okay, we will get these correct. Mary Bartram, who is the Director in Policy, and Shalene Jones, Executive Director for Eating Disorders Nova Scotia. So what we will be doing for this is each group will be given 5 minutes. That's 5 minutes amongst your group. So if there's more than one that would like to speak, please divide that time. But we are going to start the first 5 minutes, and I'm going to pass it over to Abrar. Abrar, you have the floor for 5 minutes.
Thank you so much. Good morning, Madam Speaker and fellow honorable committee members. Thank you so much for inviting me to speak today. It's such a great honor. My name is Abrar Meshmeshia, a Canadian Syrian mental health counselor with expertise working with trauma since 2014 back home and in Canada, and currently leading an organization that is dedicated to providing affordable, trauma-informed, art-based, culturally sensitive trauma and mental health support for diverse newcomers and immigrants. Our services are carried through professionals with lived experience and those who speak clients' first language. Our main focus usually women and youth. I'm speaking today from my professional and personal experience. Being a young woman dealing with layers of trauma, past trauma, who, while trying to strive, make a living, and build a future with limited support, and I'm not the only one out there. As shared in our Together Towards Recovery report, during the pandemic, my team led a national advocacy campaign to focused on understanding the barrier that mental health support and service face for marginalized youth, and undertook research to determine the impact of COVID on youth, especially those who come from underrepresented communities. Of the 308 total research participants, the majority were female. Our research showed that the primary barrier to access mental health support was inaccessibility. Many did not know where to seek long-term support. And even if they do, they were deterred by the unreasonable long time waiting long time. This relates to both geographical and mostly financial inaccessibility to the service. And those even who did get access often felt that it was kind of generic. They did not feel that they were understood. The care provider did not really understood, like they lacked cultural competency. They did not fail to understand their gender identity, their experience, the trauma that they carry on with them, and the context. One time, a young woman I was having a conversation with, she told me, well, my therapist said, if you just try to loosen up, probably, you could probably fit in or feel more included. And she was referring to her hijab and the way that she dressed. And it was like really heartbreaking for me to hear that such young women at 17 or 18 years old facing that type of discrimination within the health sector. Women, especially immigrant women, face disproportionate amount of discrimination on a daily basis and racism, which lead to increased prevalence of anxiety, depression, low self-esteem, body image problems, isolation, pressures to fit in and feel that they belong. Adding on that the layer of the trauma that they come with or they face. Yet there is very, very few services that they can reach out for help. These findings informed our vision to provide culture-sensitive, trauma-informed service for marginalized population, especially newcomer and immigrant women and girls. Throughout the last 2 years, beside of our In This Together campaign, we launched 3 projects that were focused on providing need-based early intervention for newcomer women and immigrant women. For example, our Brave Space was an early intervention support group that created to support Muslim women after the Islamophobic attack that happened in London, Ontario. We wanted that this project goal was to support women who felt threatened after what happened, and it was piloted in Hamilton, Ontario, with the support of community organizations like HCCI, SASHA, and Nenard Nan, City Councillor, and with the hope to relaunch this project again with some support. Another project was the Friends and Coffee, our first virtual support group, 12 session, in partnership with Sayan Kandia Foundation, also to support Arabic-speaking women throughout the early stages of the pandemic. Lastly, our Deal by Deal, which just launched this month, to support Afghan women, and we were that was with the support from the Mental Health Commission, which in Brazil, thank you so much, and Future Early Initiative. Anyways, so I think my time is coming up.
Your time is coming up.
Okay, what we hope to see is free, trauma-informed, culturally sensitive mental health support for marginalized women, especially and young girls, especially newcomers and immigrants, who have gone through a lot of trauma and still deal with discrimination on every day. Thank you so much, because especially Canada is an immigration country, and we really lack a lot of support that understands the migration trauma and the marginalization experience in total. Thank you so much for giving me that time and the platform today to represent many voices I'm carrying on. It's such a responsibility. Thank you so much again for listening.
Very much, and we are truly delighted to have you here today to be that voice. Thank you so much. And I'm now going to pass it over to Professor Tracy Afifi. Tracy, if you could take the floor, you have 5 minutes. You'll see me kind of start wrapping it up on the screen with my hand, so 5 minutes if you'd like to start now. You've got the floor.
Great. Thank you so much. Just want to confirm that you can hear me?
We can hear you just fine,
Yes.
thanks.
Great, perfect. Thank you so much. So my name is Dr. Tracy Afifi. I'm a professor at the University of Manitoba in Community Health Sciences and also in psychiatry, and I'm a Tier 1 Canada Research Chair. We know that mental health disorders among women and girls are prevalent in Canada. When someone begins to have a mental health problem, it can significantly reduce one's well-being and quality of life. Mental health problems can persist across the lifespan, as well as create substantial burden on society. Over time, mental health problems can worsen and lead to mental disorders, substance use problems, thinking about suicide, and attempting suicide. Mental disorders can be hard to treat. Wait times for treatment can be long. And overall, access to healthcare in Canada is limited and often inequitable. If we want to make large gains in improving mental health among women and girls in Canada, we need to focus on prevention and understanding the role that violence plays on poor mental health. Violence prevention is critical for improving mental health in Canada among women and girls. For some children, their first exposures to violence is in the home. We don't have good Canadian data to tell us how many parents spank or hit their children. However, we do know that hitting children as a means of physical discipline is common. We also know that there's conclusive evidence across decades and over thousands of studies that indicate that spanking is related to poor outcomes, including mental disorders, substance use problems, and thinking about and attempting suicide in childhood and across the lifespan. Children who are spanked are also more likely to experience severe physical abuse, sexual abuse, emotional abuse, and exposure to intimate partner violence. Our team has analyzed data from nationally representative sample of Canadian adults who retrospectively reported on their childhood experiences. We found that among women, 21% experienced physical abuse, 14% experienced sexual abuse, and 9% were exposed to intimate partner violence. Overall, 30% of women in Canada have experienced physical abuse, sexual abuse, and/or exposure to intimate partner violence. Sex differences were noted, with women compared to men being more likely to be women compared to men being less likely to be physically abused and more likely to be sexually abused and exposed to intimate partner violence. Gender-based violence is an important consideration when understanding mental health of women and girls. We further analyzed the data and found that individuals who experienced physical abuse, sexual abuse, and exposure to intimate partner violence were more likely to have depression, bipolar disorder, generalized anxiety disorder, obsessive compulsive disorder, panic disorder, post-traumatic stress disorder, phobias, attention deficit disorder, eating disorders, alcohol abuse and dependence, drug abuse or dependence, and to think about suicide and also to attempt suicide. Importantly, other research has shown that those who experience violence in childhood are also more likely to experience violence in intimate partner relationships in adolescence and adulthood. For some, violence may also continue across generations when children grow up who were abused in their own childhood and become parents and continue the same pattern with their own children. We know that violence is not the only reason why people do develop mental disorders. Genetics, environment, and other experience are important contributors to mental disorders. However, our research team hypothesized that childhood adversity plays an important role in understanding who is more likely to have a mental disorder. To test this hypothesis, our team used data from the United States and computed statistical models that are designed to estimate what proportion of mental disorders and suicidal behaviors in the general population can be attributed to experiencing child abuse. In other words, the statistical modeling estimates how much mental disorders and suicidal behavior prevalence might be reduced in the general population if the child abuse did not occur. What we found was that if physical abuse, sexual abuse, and exposure to intimate partner violence could be eliminated, then it's estimated that mental disorders among women might be reduced by approximately 22 to 32% in the general population. Suicidal thoughts might be reduced by approximately 16% among women, and suicide attempts among women may be reduced by about 50% in the general population. Even if we couldn't prevent all child abuse, making gains to reduce child abuse would likely correspond with dramatic increases in the reduction of mental disorders in Canada over time. Of course, we can't focus on prevention alone. We need to also invest in evidence-based treatments for mental disorders, substance use problems, suicide attempts, and suicide thoughts and attempts. We need to reduce wait times for care and provide better access for treatment to all Canadians, and improve targeted and combined intervention and prevention approaches as needed. If we want significant improvements in mental health, we need to work towards reducing all types of childhood violence, including spanking. Preventing childhood violence is difficult but possible and is critical for better mental health outcomes among women and girls in Canada. Thank you.
Thank you so much. And staying on Zoom, I would like to introduce to you Jennifer Colo, the psychologist, professional specialized eating disorders program from BC Children's Hospital. Jennifer, you have the floor for 5 minutes.
Thank you so much, Madam Chairperson, and to the committee members for inviting me here today. I'm coming here from Vancouver, which is the traditional unceded territory of the Musqueam, Squamish, and Tsleil-Waututh people. And also, in addition to representing BC Children's Hospital Eating Disorders Program, I'm the president-elect of the Eating Disorders Association of Canada. Now, back in 2014, the Standing Committee on the Status of Women published a report on eating disorders in girls and women in Canada, which references the services for eating disorders being in a state of crisis. And the pandemic has really exacerbated this crisis and created a perfect storm of factors that has led to increased presentations of new eating disorder diagnoses across Canada as well as internationally. We know that biological and genetic factors interact with psychosocial challenges in the development of eating disorders. And the psychosocial challenges in the context of the pandemic, including disruptions to daily routine, decreased opportunities for physical activity, and increased social media use, are thought to be contributing to the surge in eating disorders. Now, in terms of the details of the surge, a report published by the Canadian Institute of Health Information reported that hospitalizations for young girls and women with eating disorders between the ages of 10 and 17 years increased by nearly 60% during the pandemic, and data from different Canadian eating disorders programs report similar or even larger increases. Now, although the study is currently focused on mental health in girls and women, I do want to highlight that eating disorders are diagnosed in people of all genders, as well as all racial and ethnic groups, people of all body shape and weight, and socioeconomic backgrounds. And eating disorders are a crisis, a health crisis that can be fatal, and in fact have one of the highest mortality rates of all mental health diagnoses. And because of that, intervention is really critical to prevent lifelong fatal consequences. But people with eating disorders experience a lot of barriers in accessing services. And these barriers can include exclusion criteria for referrals or challenges in finding healthcare professionals who offer services for some eating disorder diagnoses. For example, services for an eating disorder called avoidant restrictive food intake disorder, also known as ARFID, which is a newly emerged eating disorder diagnosis, vary depending on where an individual lives, and typically are focused on pediatric services. So individuals with ARFID may present in a variety of mental health settings outside of specialized eating disorder services. And research from our group has demonstrated that healthcare professionals, particularly those who do not specialize in eating disorders, report very low confidence in providing clinical care for individuals with ARFID. In looking for a path forward, we can look to our international colleagues who have developed innovative service models that can be adapted for a Canadian context. For example, Australia has created a National Institute for Research, Translation, and Clinical Excellence in Eating Disorders, and in 2021 released a National Research and Translation Strategy for Eating Disorders. I would argue that the development of these national resources has contributed to innovative service models, including models that are focused on early intervention. Similarly, in the UK, there's a new intervention known as the First Episode and Rapid Early Intervention for Eating Disorders model, or FREED, which focuses on rapid response to referrals with benchmarks for service provision, including telephone screening within 48 hours of referral and assessment in less than 2 weeks of referral. So as the committee looks for pathways forward, I want to highlight the existence of the Canadian Eating Disorder Strategy, which was published in 2019 and is a 10-year strategy outlining 50 recommendations aimed at improving outcomes for individuals with eating disorders. And these recommendations remain relevant today. And they were developed in collaboration with the 4 national Canadian eating disorders organizations, together with input from stakeholders. Thank you so much.
Thank you so much for your intervention. We're now going to pass it over to the Canadian Mental Health Association. And here today we have Sarah Cannell, National Director, Public Policy. Sarah, 5 minutes.
Thank you very much, Madam Chair, and good morning, esteemed colleagues. Bonjour. The Canadian Mental Health Association is the most established, extensive community mental health organization in Canada, providing advocacy programs and supports and resources that prevent mental health problems and illnesses and support recovery. We reach 330 communities in every province and the Yukon, engage 11,000 volunteers, and employ over 7,000 staff. Age and gender are major determinants in accessing mental health supports. According to Mental Health Research Canada, women under 25 are overrepresented among those with high anxiety, stress, and depression, and are less likely to seek out mental health supports, citing inability to pay or not having enough insurance to cover as barriers. In the past 10 years, suicide rates among women have overtaken men in the 10 to 14 age range. Girls are 6 times more likely to develop general anxiety disorder than boys, and there is a marked increase in incidence of major depressive episodes among girls over the age of 13 compared to boys. Structural inequalities in our mental health system exacerbate these gender-based inequalities. Canada's universal health system isn't universal at all. For services to be covered, they must be deemed medically necessary under the Canada Health Act. Mental health and substance use health services delivered outside of hospitals and by physicians are not considered medically necessary. This means services like counseling, psychotherapy, substance use health treatments, for example, fall outside of our public health system, leaving people to rely on limited insurance benefits or having to pay out of pocket to get the care that they need. Many turn to not-for-profit organizations to access these services. Long wait lists, geographic barriers, system navigation issues, cost-prohibitive care, and lack of access to community-based supports compound and intersect along gender and age lines. Speaking with young women with living experience of mental illness and the frontline mental health care providers that support them, young women and girls face particular challenges navigating the system. They can feel a lack of agency and powerlessness, and that recovery depends on the privilege of income and time. Speaking to interactions with the acute care system as young women, they describe needing to be in crisis or sick enough to get the care that they needed, and left to navigate the system by themselves without access to community-based supports once discharged. Power dynamics rooted in patriarchy perpetuate harmful gender stereotypes that permeate the mental health care system. When seeking mental health supports, young women can be perceived as quote-unquote overdramatic, resulting in barriers in access to care. One woman that we spoke to about the gendered ways in which physicians can impose judgment and pressure to adhere to treatment plans, saying specifically that they promoted medication over therapy-based treatments despite raised concerns about risks associated with such medications, including suicidal ideation. Speaking specifically about eating disorder treatments, we heard about young women being released from treatment if they were non-compliant or if they failed to meet treatment goals. On the issue of suicide among young women and gender-based stigma, research suggests that they are, quote-unquote, attention-seeking or manipulative and not taken seriously. Current responses to suicidality often fail young women by not creating the supportive environments to truly meet their needs when they are seeking help. Upstream mental health promotion initiatives delivered by community-based organizations like social and emotional learning, mental health literacy, comprehensive sexuality education lead to healthier relationships, reduced bullying, and improved self-esteem by addressing toxic masculinity and harmful gender stereotypes. These programs are critically meet the most vulnerable in our communities and yield strong returns on investment. Connection, wraparound supports, follow-up, and gender-sensitive and age-appropriate care is equally important. However, the existing supply of such programs cannot meet the rising demand. But the federal government can help. Most critically, the federal government can create the promised Canada Mental Health Transfer. CMHA is calling for the equivalent of 12% of provincial and territorial health expenditures, or $5.3 billion expensed annually, with 50% earmarked for community-based services, accompanied by a Canada Mental Health and Substance Use Health Act to bring permanency and accountability to the transfer. Bringing an intersectional gendered lens to mental health helps us better understand the different needs of women, girls, trans women, and non-binary people, and how best to respond to those needs. Left unaddressed, mental health issues experienced at a young age can turn into more serious mental health issues later in life. As a country, we've failed to invest in mental health and substance use health, and it shows. CMHA looks to this committee to support making mental health a priority now. Thank you.
And thank you so much. And finally, from the Mental Health Commission of Canada, we have President and Chief Executive Officer Michael Rodrigue. Go ahead. You have the floor for 5 minutes.
Bonjour. Merci.
Hello. Thank you again for all the time that you're spending on this important issue. I am honored to appear before you to discuss such an important topic, the mental health of young women and girls. For those members who are not familiar with the Commission, it is responsible for the development and dissemination of innovative programs and tools that promote the mental health and well-being of Canadians.
With regards to your committee's study, the Commission's researchers have noted a gender paradox, where men are more likely to die by suicide. However, women are more likely to attempt suicide. For us, there is a clear opportunity to support women and girls early on in their life so that they have the tools they need for mental well-being during their entire lives. In 2023, the Commission will be embarking on a suicide prevention effort among women and girls. We would be pleased to come back to this committee to share some of the findings. I'm also happy to see Abroad Trauma here today. The MHCC was pleased to recently partner with them on Dil by Dil, a program for Afghan newcomer women. I would now turn to my colleague, Dr. Mary Bartram. As well, online, we have Shailene Jones, who's a member of the Commission's Hallway Group. It's composed of people with lived and living experience of a mental illness. And she is also the Executive Director of the Eating Disorders Nova Scotia. Over to you, Mary.
Merci, Michelle. Bonjour tout le monde. I'm
Thank you, Michelle. Thank you.
to provide a bit more information about the Mental Health Commission of Canada's research and programming. Findings from our COVID polling with the Canadian Centre on Substance Use and Addiction were very clear and concerning. Mental health and substance use concerns were greater for youth overall and differed significantly by gender. We'll table a more detailed report soon, but here are a few highlights. Half of young women, and here we're talking women aged 16 to 24, and a third of young men reported moderate and severe anxiety symptoms. Again, that's half of young women and a third of young men over the course of the pandemic. And when it comes to substance use health, 2 in 5 young women who use cannabis reported problematic use, as well as 3 in 5 young men. These impacts compound for youth that identify as 2S LGBTQ+, who report low incomes and who are from ethno-racialized communities. The MHCC is developing a lens for mental health policy and programming that integrates sex and gender, but also intersectionality, anti-racism, and decolonization, to name a few. And again, we'd be pleased to come back to share more with this committee as that work develops, as it may be of interest. We also have several programs making a difference for young people, including young women and girls. So, for example, over the past year, we had over 800 teenage girls who participated in our Headstrong anti-stigma summits. We also offer supporting youth mental health first aid training and work with campuses across the country to adopt and implement the national standard for mental health and well-being for post-secondary students. I'm pleased now to turn things over to Shailene Jones, who will speak to more on the important mental health priority, eating disorders. Thank you.
We've got about 45 seconds left, Shailene, about 45 seconds.
Well, thank you all so much for inviting us all here to speak about this really important issue. I really want to echo what we've heard from a lot of the panelists. I am a survivor of an eating disorder, and we know that eating disorders are complex, common, serious illnesses with the highest mortality rate of many mental illnesses. In the mental health community, we've been calling the alarm on eating disorders for 20 years. And we are in a grave situation. Indeed, this is a crisis point. We know that with rapid access to early intervention, treatment, and support, people can and do go on to lead fulfilling lives and to be able to fully recover from this illness. But too many are denied the opportunity to recover. I want to call upon all aspects of our community to enable several recommendations. And again, streaming from the work done by the National Eating Disorders groups. We need rapid access to low barrier support, including peer support, support for families, training for clinicians, and training on early intervention for primary healthcare providers. And finally, funding for community-based organizations that are picking up a credible burden for supporting folks with eating disorders. Here at my organization, Eating Disorders Nova Scotia, we have been providing peer support to folks in Nova Scotia for the past 20 years. We're now extending this across Canada because the demand is so great. So I look forward to working more on this issue collectively with you all. Thank you.
Thank you very much. And Shailene, thank you very much for being here and supporting what we're doing. So what we're going to be doing is we're going to be going over to our rounds of questions. For the rounds of questions, to start its first round, each group gets 6 minutes. So I'm going to pass it over to Michelle Frary for the first 6 minutes. Michelle, the floor is yours.
Thank you so much, Madam Chair, and thank you to all of our witnesses. Nice to see some familiar faces here. If I may, I'm going to actually address this question to two groups, so I'll give one person a chance to think about it. The other person will have to answer it right off the hop. Sarah, may I call you Sarah? Yeah. Michelle, may I call you Michelle? The question, and I'll start with you, Sarah, is I think we've made great strides in convincing people to not be afraid to ask for help. So now we have a lot of people who have overcome that hump. They're ready to ask for help, in particular children or parents of children. So they're ready to access help. They take that brave, courageous step, and then there's nothing there for them when they do ask. What is the number one thing we can do as a federal government to close that gap to access to treatment for mental health supports?
Thank you, Madam Ferrari, for that question. I couldn't agree more. We've done so much great work on raising awareness, breaking down stigma, and addressing this discrimination associated with mental illness and substance use health. But the challenge really is in where do you go for help? We shouldn't have a country where in order to get the help that you need to be in crisis. And crisis means going to hospitals to get the care that you need. We need to have more cost-effective and community-based care. And the role of the federal government is, in my opinion, directing resources to provinces and territories to fund community-based organizations. So that's that out-of-hospital care that people rely on in community. It's culturally appropriate, it's trauma-informed, it's age and gender sensitive. It's integrated youth hubs, for example. So really it's about ensuring that we're allocating those federal dollars, both through the health funding that is transferred to provinces and territories, and then direct investment through grants and contributions from federal departments to those community-based organizations doing that work.
Thank you so much. Michelle, if you don't want to add, do you want to add to that?
Sure.
Yeah.
Thank you for that. I will readily say that it's complex, but a couple of things really come to the forefront. First, you still need to continue on prevention. And part of that is making sure that in elementary school and secondary school, people learn how to speak about mental health, mental illness. So mental health literacy is so key.
May I just add to that, because that was actually one of my next questions. Do you think mental health first aid should be readily available to everyone who is working with children, caregivers, coaches, et cetera, and an age-appropriate mental health first aid for young children as well in the education system?
Very much so. I think it's time for that to be pervasive throughout our workplaces and whoever works with children, with teenagers, as well as creating safe post-secondary campuses as well. So thank you for that question.
Yeah, I'm a big ambassador of mental health first aid. I would ask, I guess, my next question to you again, Michelle, if you don't mind, the tax on psychotherapists. For people who may not be familiar with this, right now there is a tax that psychotherapy is getting that other service providers are not psychiatrists. Have you had an answer from Finance Canada as of yet as to why psychotherapists are being taxed and other providers are not?
I'll take this one. Thank you. So the whole issue around the regulation of psychotherapists is a priority in Canada. We have 5 provinces that are regulating psychotherapy or counseling therapy, and the issue of tax is tied to the regulatory status of psychotherapists. So if we can complete the regulation of psychotherapy across the country, I think that this issue will work itself through to be on a par with other types of healthcare providers. And I can add as well that the issue of a need for a national mental health and substance use health workforce strategy that addresses this amongst a range of other issues as part of the prioritization of the health workforce right now is another area where the federal government could have a role to play in making sure that that focus on health workforce includes a variety of issues related to mental health and substance use health workforce as well.
Do you know what the holdup is on why the regulation hasn't happened for psychotherapy?
Again, these are complex issues that get played out at the provincial level in terms of whether it advances or not. Most provinces have pre-regulatory bodies in place, so a federal push might be something that could be of assistance in getting those processes over the hump.
I know I don't have a lot of time left, and this is a very loaded question. I'm going to drive it to Sarah because you addressed it a little bit in my first question. The Canada Health Act, what needs to be changed in it in order to make mental health accessible to everyone? Mental health care accessible
Thank you.
to everyone.
Yeah. A reopening of the Act and a clarification on the list of medically necessary services would go a long way to ensure that the services that are now left out of the system are integrated. So as I mentioned, counseling, psychotherapy, substance use health treatments, the services now that we rely on insurance or paying out of pocket for, that is one avenue. An alternate avenue is to create a parallel Canada mental health transfer, I should say, an accompanying act that would create dedicated funding for those services that fall outside the system.
There was a dedicated promised $4.5 billion that was promised by the federal government to mental health transfers. Where is that?
That would be a question for Minister Bennett.
Fantastic. Thank you so much, and we'll get back to you. I'm now going to pass it over to Sonia Sidu. Sonia, you have the floor for 6.
Thank you, Madam Chair. Thank you, all the witnesses, for your insight testimony. My question is to Ms. Coelho for the eating disorder. We know eating admissions is on the rise in ER. And then what do you think, what is the role of the social media who has to navigate like the beauty, to look at the beauty? Do you think the role of social media is also impacted on that?
I think, as we're hearing some of my fellow witnesses today highlight, it's complex. And so when we talk about the perfect storm of eating disorders, the increased use of social media is one of the factors that has been highlighted. At the same time, we know that social media in and of itself does not cause eating disorders. And I think what's challenging is that we're also in a context of what is known as normative discontent. And so I think a lot of girls, young women, as well as boys and transgender, non-binary individuals have challenges with body image and maybe trying to change their body image. And it may not go to the point of an eating disorder. And I think that some of the witnesses who are highlighting the importance of prevention and mental health, body image is a factor of well-being that fits within that. And I think that's where some of the main concerns around the impact of social media also lie, not only in the clinically diagnosable eating disorders.
Next questions to Professor Tracy Afifi. And my colleague just raised this, the educational help for the mental health. Does parents, when parents are open with the children about mental health, what can parents can support their kids, and then plus the educational side, how we can fill that gap?
Thank you. So I agree with being able to focus on prevention, as was mentioned here already. So we want to make sure that when children are having difficulties, the sooner they have access to care, the better. Again, repeating what other people have said, we don't want to wait for anyone, children or adults, to be in crisis before they get care. So education in terms of how they can talk about their mental health, give them resources both to the parent and the child. So the parent and child have to be a unit to help the child. We can't just focus on giving skills to the child, but the parent also may need skills as well in order to be able to perhaps even handle their own stress and concerns, and then also to be a support for their child. We need to make sure that access to care is early. So we can't wait till a child is 12 years old or an adult is 18. We need to be starting really, really early. And then when people have concerns with mental health and reach out, those services need to be in place across the country in all locations, because when you have an issue with mental health and you're told that you need to wait 6 months or 12 months, that's the worst news you can possibly hear as a parent or as a child, because when you need help now. And so we need to be able to make sure that when people are asking for help, those services are in place for everyone in the country.
To Dr. Cleo, we know the pandemic has created a demand for virtual delivery of eating disorder care too. Is virtual delivery is effective when it comes to eating disorder? Just want to know that.
Yeah, so there was a Canadian consensus panel that put out guidelines for treatment of pediatric eating disorders. And then last year, there was an addendum where there was an analysis of virtual care for eating disorders and recommendations that there is emerging evidence to support this approach. And in fact, although there's challenges in some rural and remote areas in terms of internet access, that it may be an approach that allows more equitable access to individuals, because the eating disorders programs in Canada tend to be based in urban and suburban situations geographically. And so many programs are using this with great success, and there's emerging evidence about virtual approaches.
Thank you. Next question to Ms. Meshimishia. You talked about the racialized women and then how they can get the services of mental health, and heard some barriers too. And then we heard from Ms. Cannell, like if the community-based programs, where's the gap and how the federal government can improve that gaps, if both can put on the comment on that.
Thank you so much for your question. Just to clarify, you mean the gap between, like, how can the federal government get funding to the community-based, let's say, resources or services to support racialized women or, marginalized population and young girls, right?
The first part, how the communities, organizations can help the newcomers or the racialized women.
That's a great question. So, in supporting them with early intervention mental health support that is catered towards their trauma that they have and the culture that they come from. For example, now, especially now, we're opening to multiple different variety of cultures like Korean, Afghan, Middle Eastern, and etc. So first, providing that type of support. The other thing is creating more safe spaces. So the first support would be providing the early intervention that looks like peer support.
Abrar, we're going to have to get back to that question and to that answer because we're quite a few seconds over time. So we will come back to you. But I'm going to pass it now over for the next 6 minutes to Adrian. Adrian, you have the floor for 6 minutes.
Merci beaucoup. Thank you very much, Madam Chair. I would like to thank the witnesses this morning. So, if I've heard everyone correctly, we need to work on prevention, work uphill, and raise awareness with young women and girls. In Quebec, we are quite proud of our community model. We've been working on this since the 70s, and we are people who work on the front line of prevention. I received a call this morning from a social pediatric center, and these centers have developed greatly in Quebec. They can be found everywhere, and they are working on their food drives, and they work on prevention with families experiencing violence and families that are facing difficulties. I also worked with a suicide prevention center. They have a program focused on prevention in the workplace, in schools, and others. They talk about mental health and suicide prevention. They were talking to me about the problem of the lack of staff, and they don't have the funding to pay their staff. So I'll give the example. There are programs and services in place, and the Quebec government would like to fund these community groups more. But in Quebec, it goes through the Ministry of Health and through health transfers, and you mentioned it. The importance of having the financial means to offer funding to these mental health services, because there is such a community network that is working on the field every day on prevention and to work on emergency situations. I would like to come back to the importance of those health transfers. And there are projects already that exist, so what is the importance of not having an overlap of efforts when there are already projects in place? If you want to tell us more about that. Thank you very much.
I think it's about scaling up and supporting existing initiatives that we know are evidence-based, that we know we get the results that we want to see. I would comment on two things. One, the salary equity issue. L'équité salariale, c'est vraiment une priorité.
It is a priority throughout Canada. We are not paying our social workers enough.
Pay equity across our acute and non-acute hospital-based, non-hospital-based healthcare settings. The other issue that we experience is not only our frontline mental health care workers working in the community, working at a reduced salary, they're also experiencing higher levels of burnout and stress and leaving the profession, often going to the private sector, leaving community-based organizations without the adequate staffing needed to really sustain, scale up, bring sustainability to their programming. When it comes to the Canada Mental Health Transfer, as I said, we need to see 50% earmarked for community-based care. We know that investments are already going to hospitals and physicians through the Canada Health Act. So really the Canada Mental Health Transfer has the opportunity to redirect resources into the sector that has been starved for resources for decades now. And that's been a problem created through the Canada Health Act. So by creating the Canada Mental Health Transfer, we can see an influx of resources to these organizations, Madame Laroche, comme vous avez mentionné.
As you mentioned, that need these funds, they need the means in order to support their prevention programs. Thank you.
C'est intéressant et
It's very interesting, and Ms. Kennel, with the $5.4 billion, because when I hear us talk about transfers and conditions, I hear that this funding can be per project, whereas what is requested by community organizations and by Quebec and the provinces is stable, foreseeable funding. So when we're talking about $4.5 billion, that seems good, but when it's by project, that's not reflective of what is being requested by community organizations. They want foreseeable funding and stable funding. I would like to hear you talk about the importance of that aspect of health transfers and increasing it significantly as well, because we are requesting 35%, because we're hearing this morning the importance of investing significantly in the healthcare system. If you could say more on that, please. Answer. I would like to add that the transfers need to be permanent, not over 5 years, something that would start next year, we hope, with the budget for 2023.
Parallel track of funding, because what we're seeing is organizations are having to apply for short-term grants, often pilot projects, that really prevent them from being able to build in sustainability, retain staff, and recruit staff, and pay them adequately. So rather than seeing community-based mental health as charity that's offered by small donations here and there, we're really wanting to institutionalize the system and see it as part of our healthcare system, which mental health is.
Fantastic. Thank you so much, Sarah. We're now going to pass it over to Leah Gazan. Leah, you've got the floor for 6 minutes.
Thank you so much, Chair. My first question is for Abar, is that right? And Michia? Mamushia. Oh, okay. Sorry about that. So you spoke a little bit about one of the barriers being the cultural competency of therapists providing care. You spoke about, gave an example, for example, the Islamophobic attacks that happened in Ontario and the impact on mental health. I know in my riding of Winnipeg Centre, it's rich with diversity, but I would agree with you. We lack appropriate care, culturally competent care, particularly for newcomer youth. And adult women that are often experiencing things like, for example, war trauma. So I wanted you to speak to that. I also wanted you to because I don't have a lot of time, speak about art therapy. We have a program called Art Beat, and that works specifically with it. They provide internships for people that are experiencing mental health issues. And I'm wondering if you could speak to the importance of art as a therapy.
Thank you so much. So to comment on the first part, it's amazing that I know that Winnipeg has a diversity background, and really, they're doing great in terms of having more of variety and culture sensitive support. So in order to add to that, I think what we need is to have community-based, as already echoing Sarah on that, community-based organization that provide early intervention, safe spaces for these newcomers, women and immigrants, that understand the trauma that they bring and speak their language and from their culture. So having that and a lot of funding towards that. Art, absolutely, it's when you don't have the words, art is a great way to express yourself and a great healing great way to heal. So we did find art therapy is super effective when I used to work back home in with War Survivor and currently, and we've led a lot of art therapy workshops with newcomer immigrants, and also some the art therapists that they lead the session, they also come from the same culture. So I think especially with the language barrier, art could be a really great alternative to give them the space to express their trauma and their feelings. Thank you.
Wonderful. Thank you so much. My next question is for Mary Bartram. You spoke a little bit about consumption. Our party, the NDP, put forward a bill, a health-based approach to Substance Use Act. It was defeated, unfortunately. I just want to give you a quote. It says, and it was from the British Columbia Centre on Substance Use. They said the following: as well, we must end racism and sexism against Indigenous women, girls, and Two-Spirit people, as described in the report of the murdered and missing Indigenous women and girls. In 2020, women accounted for 32% of toxic drug deaths among First Nations people in BC, twice the rate of the general population. Going on to say that in the National Observer, in an article they found, in quotes, the coroner's service in British Columbia says more females are dying from illicit drug use in BC. I'm sharing this because I find that, you know, as elected officials, instead of taking a public health approach to toxic drug supply use that is impacting more prominently other groups, certain groups than others, why is it important to take a health-based approach to consumption rather than an approach based on stigma?
Absolutely, we need health-based approaches to the issues around toxic deaths from toxic drug supply, but to the mental health and substance use impacts of the pandemic more broadly as well, which, as you know, has been closely intersecting with some of the issues that you raised. So again, a health-based approach with a focus on prevention, social determinants, reducing risk factors, adequate funding for equitable access to quality care that's culturally competent, the importance of having the right capacity in the system to respond to those emerging needs. All of those pieces are very much part of a health-based approach and very important.
So I asked that because in Manitoba, we recently got the first of its kind, a peer support van, not a consumption. We don't even have consumption sites, safe consumption sites in Manitoba. Even a peer support van was difficult because of stigma. Because of the fact that people that are suffering from addictions are so stigmatized, there seems to be this idea that they don't even deserve support when they're using. Would a federal response to this overdose crisis, rooted in mental health, often mental health and trauma, be helpful?
Well, I think that the federal government is working on several fronts around substance use stigma and around the overdose crisis, but we see that crisis is still impacting the country in a very deep and profound way. So I think more is always helpful.
Would decriminalization...
Awesome.
Okay,
we'll
sorry.
get back to you,
Okay,
Leah.
thank
We'll give you some more time.
Thank you.
Okay, so we're now going to turn into our next round, and it's going to be 5 minutes each. I'd like to turn the floor over to Anna Roberts, and welcome Anna to FEWO.
Well, thank you very much. It's a pleasure to be here, and thank you, everyone. So my first question is to, is it Ms. Jones on the eating disorder? So I recently met with some young children who were bullied at school because of their shape, size, whatever. And when I approached the teachers on education, how are we educating the young students? Because let's face it, if we don't, the younger they are, if they develop a certain skill or they develop a certain, I shouldn't say this, but nasty attitude, it'll continue with them for the rest of their life. How can we improve that education at that level?
Great question. Thank you so much. And I think you've hit upon something really important here, which is we have to look at young people in the context in which they lead their lives. And so while it's important to do health promotion within the schools and early intervention for eating disorders and work around body image, it's important to recognize too that they are surrounded by adults who we also bring our own prejudices around weight and shape and size and our own judgments around what is healthy. And so really looking at systems and how do we address weight stigma and healthism within systems that are surrounding our young people, I think is really essential.
Thank you for that. So being new to this committee, and I understand that the government has promised the $4.5 billion to assist with mental health and the disorders. Why is it that, I guess I'm trying to understand, when we've just gone through the worst 2.5+ years with COVID, a lot of young children became depressed. A lot of them developed eating disorders because they were bored, they couldn't get out, they couldn't see their friends, they couldn't move on. Why is it that we're so slow in acting and ensuring that we haven't taken aggressive procedures or aggressive manners to help in that area? What do you think we need to do better?
That's the million-dollar question, right? In the 2014 report on eating disorders of women and girls, one of the witnesses said that if eating disorders was an illness that affected men, like prostate cancer, there would be an eating disorders clinic on every street corner. And so I think it's valuable for us to take a gender equity lens to this issue and know that it impacts predominantly women and girls, although of course it does impact men and boys as well, but it's seen as an illness that impacts girls and women, and it's seen as a feminine behavior that stems from looking at Instagram too much and just not loving our bodies enough. And so we reduce it to an individual problem that girls need to just grow up, snap out of it, eat a sandwich, right? We've heard all of this. And these are such complicated, metabolically, biologically driven, complex illnesses. And I think we have been delayed in taking action because of the lack of gender equity lens to approaching eating disorders, and because they are very complex and there isn't a one-size-fits-all solution to this.
Thank you for that. So my last question to you is, I recently met with a seniors group, and we talk about young children, we talk about the stats, and it's generally this eating disorder is among young children. I wasn't surprised to hear that some of these seniors, I don't know if it's an eating disorder, if you would refer to it as an eating disorder, but given the cost of inflation, they've had to reduce, let's say, their healthy meals as opposed to, making sure that they have enough money at the end of the month to support them. So is there a program, or do we have any stats on older individuals? Like a lot of the homes, or a lot of the women, let's be honest, women outlive men, no offense to the men, but we all know the stats that this is the case, and then therefore their pension or whatever is reduced once the spouse has passed on. Is there any programs or any numbers that we have to find out about that?
Yeah, absolutely. We can follow up with numbers on that. And we know that eating disorders generally tend to start in adolescence, but for a variety of reasons, including lack of access to treatment, people still have them in midlife and late life. So this isn't an illness that appears in adolescence and then disappears when they hit a magic number. So we have a lot of folks within Canada who are currently adults and seniors who are still struggling with an eating disorder. We're also seeing disproportionate numbers of folks who are food insecure who are facing eating disorders. So again, they're really complicated issues, but often connected to tremendous distress and lack of food availability.
Excellent. Thank you so much, Shailene. We're now going to turn it over, and on screen we have Jenna Suds. Jenna, you have the floor for 5 minutes.
Thank you very much, Chair. Good afternoon, everyone, and my sincere thanks to all of the witnesses that have joined us today for your testimony, but also for the incredibly important work that you do each and every day. I think I'll direct my first question at Ms. Mechia. I wanted to dig a bit on, I know one of the projects that you have underway, I believe it's called Brave Space, which is helping to support Muslim women, in particular after recent Islamophobic incidents in our country. And I'm wondering if you can speak to us a bit about the impacts of Islamophobia on mental health for young women in the community. And then secondly, I'm thinking about world events and, what we're seeing this, such as of course, the tragic death of Mahsa Amini, and this outcry and championing of women's rights in other parts of the world. I'm wondering if you can speak to that as well. Thank you.
Thank you so much, Jenna, for your question. Well, when we speak about the impact of the Islamophobia, it's on daily basis. You face discrimination, racism, and that absolutely lead to you feeling. First, you feel afraid to walk on the street. Like the participant that we did have at the first pilot, they reported feeling not safe to go alone at night, not feeling safe to be in the bus by themselves, or informing their, for example, friend or spouse that we're, for example, at this location, especially after the incident. I personally did not allow my mom to go for a walk by herself because she wear niqabs. I was like, no, I'm not gonna risk it. So feeling afraid, feeling scared, that absolutely lead to feeling depressed, a higher level of anxiety, probably PTSD, because it's a trauma that lead to you're witnessing the trauma. Anyways, so also feeling isolated because there's not much support and you feeling that you're being targeted. So a lot I can speak on the impact of the mental health that women go through, especially as you said, after witnessing other like what happening to women in Iran, for example. I've been having conversation with Iranian girl just a couple days ago, and I was just checking on how are you feeling. And some of the professionals at the team, they feel devastated, and they say what support. Also, the people who live in Canada, they have families there, and they cannot they don't know who to turn to for that support to talk about their experience and how to express that devastating feeling that they're going through. When we did the pilot, we did 4 sessions, and now we expanded to 8 sessions, and we applied for Islamic Relief for more support. Women did require to be trained for the self-defense techniques, and that was surprising. Not just the mental aspect, that they feel not safe even in Canada. I don't know if I have more time to talk, but thank you so much for your question. I hope I give you some, gave some insights.
Yeah, thank you very much, and I'm glad to hear that Brave Space is continuing. I will turn my next question to Michael Roderick, Mr. Roderick. We've heard a bit today about kind of some of the tools that are being used, electronic tools, if you will, for mental health resources. And I'm wondering if you can speak to whether these are being well received among youth. And I ask that in that, I think part of the problem, as we've heard, is children gravitating towards technology and spending a lot of time on social media. And so then I posit, as a mother as well, whether then receiving health resources when a child is struggling with mental health issues via Zoom or other electronic means is welcome, and whether it's effective.
Yes, it is welcomed. It is an efficient way to provide service when and where it is needed, and it is as effective as face-to-face counseling, for instance. So it is really part of that toolkit that we need to roll out. We need to prepare and support service providers because magically they're not trained to provide that support. But yes, text-based, internet-based, phone-based are all very effective, and for some, it's actually easier to interact because you don't need to go into an office. There isn't that daunting element.
Awesome. Thank you so much. We're now going to pass it over for 2.5 minutes to Adrienne. Adrienne, you have the floor.
Merci, Madame la Présidente.
Thank you, Madam Chair. I will now ask my questions to Dr. Afifi. In your opening remarks, you talked about the importance of violence in the home on mental health and the importance of working on prevention to decrease violence against women, which also impacts children. In Quebec, there is a report called Rebuilding Trust that has hundreds of recommendations to work on intimate partner violence and violence that has an impact on families. There's the matter of investing in groups that support women who are victims of violence. Often when there is duplication of services, during the pandemic, there were funds given to shelters, and it's important to invest more and invest more quickly, and these groups keep saying that they need more resources to welcome these women. So there's a link between the funds and the support that can be given to these women.
Professeur Afifi, est-ce que vous avez entendu?
Dr. Afifi, were you able to hear my question?
Yes, I was. I didn't. I heard more of a statement than a question. Are you asking if these funds are helpful in reducing violence?
En fait, ce que je veux dire,
I was saying that there are community groups that have projects and they want to develop further projects and have more spaces for women. But during the health transfers, the federal government tried to put conditions to these transfers, even though the Quebec government had agreements with community groups in the field, and they wanted to transfer the funds as quickly as possible. So when we're trying to put conditions on these, it causes a duplication of services or slows down these services. But can you talk more about the importance of increasing help to these groups and these women?
We only have 2.5 minutes, so we do not actually have time for that answer. So on that, I will ask if we either come back to it, Adrian, when it's your next turn, but I will pass the floor back over, and if we can just hold on to that, I'll pass the floor over to Leah Gazan for her 2.5 minutes, and then we'll try to get everything back. Okay?
Thank you so much. Sure. My question is for Sarah Cannell. Cannell, sorry. I hate pronouncing names wrong. But going back to my last question, so Manitoba, I was talking about the peer support van. That was an issue. We've had more people die of overdose in Manitoba in the past year than I've ever seen. I think it's over 500, which is a lot for...
Please turn off the microphone of Adrienne.
Oh, Adrienne. Oh, sorry. Sorry, there was difficulty in it. It is on? Okay. Would decriminalization, I'm just assist. I say this because, you know, what my thinking is that people, if they feel that they're going to get in trouble for getting help, for being open about issues, would decriminalization assist individuals to get help? And I say that in regard to women because in the BC study, the coroner's service in BC Columbia says more females are dying from illicit drug use. It says that while men have historically accounted for nearly 80% of fatalities, more than 26% of those who died in April were female, continuing a trend that began earlier this year. So we know the rate of deaths among women and young women are going up. Would this help decriminalization?
Thank you for your question, Ms. Gazan. Yes, we know that research demonstrates that the impact of the criminalization of substance use leads to deterring people, particularly marginalized, vulnerable people, including women, trans women, non-binary folks, from not only seeking care, but also delaying access to care and further pushes them underground, where they have fears of arrest, fears of criminalization, fears of child apprehension. So the system that surrounds criminalization actually has a ripple effect that is worse, and CMHA is advocating for a nationwide approach to decriminalization to respond.
So would you say that stigma around addiction and drug use, would you say that is in fact costing lives in terms of a failure of elected officials to support decriminalization? In spite of the public health research, sorry.
We know that taking a health-based approach leads to positive health outcomes and reduce arrests and reduce of criminalization, which ultimately benefits society as a whole.
So in fact, it's almost like a crime prevention strategy if it's a
health-based approach reduce criminalizations, yes.
We're now going to pass it back to Michelle Frere. Michelle, you're back to 6 minutes.
Thank you, Madam Chair, and thank you to everybody and witnesses again. Thank you for being here for this. I'm curious if we can touch on, I believe it was Miss Jones, Shailene Jones, if I may call you that, Today, actually, ironically, Uber is making cannabis available for delivery in Toronto. So I'm really curious on your thoughts on what you think the impact will be. I guess I will boldly ask you if you think cannabis should be as readily available in Canada as it is.
Is this question for Shalene Jones?
It was under for, I believe it was, or was it Mary? Who spoke about the cannabis? Was it Mary? Sorry, Mary. Sorry about that. Mary. Sorry about that, Shailene.
Should cannabis be as readily available as it is? Because of the Cannabis Act, it's there's a regulatory framework for making cannabis available under certain restrictions. The Cannabis Act is currently under review, which is just opened up a few weeks back. It's very difficult to know whether legalization has driven the increased rates of cannabis use among those who use that I mentioned earlier, or how much of that is part of the response to the stresses and distress during the pandemic, the social isolation, that whole constellation of mental health and substance use impacts. So I think that the answer to your question is going to be examined over the review of the Cannabis Act, and we have a suite of research on the relationship between mental health and cannabis that the Mental Health Commission has been funding for the past 5 years. So we look forward to bringing those findings into that conversation. So it's not a direct answer, but nevertheless the one that I would give.
And for sure, and I think it's an important conversation to open up. And there's a distinction, obviously, between recreational and pharmaceutical use, for sure. And I want to be clear on that. I guess where I'm going with it is, we do have an increase of stress, and we do have an increase in maladaptive coping mechanisms, not just for adults, but for children as well, as they try to navigate the social stress that's been put on them, and now an affordability crisis, which we've heard from other witnesses is downgraded or downloaded to the children. And I guess, would you want to see research on what happens to those young developing brains that are turning to cannabis as a maladaptive coping mechanism because they don't have access to the support or healthy coping mechanisms that should be available when they need help or counseling?
Well, I absolutely think that children and young people who are experiencing mental health concerns should have access to high quality treatment that's culturally competent and equitably funded, low financial barriers, 100%. The other parts of the question, I think it's sort of packing too many things in to be able to give a resounding yes, but we need that access to care and for people across the lifespan, and the importance of early intervention, early age, like making sure that kids in particular have access to those services and supports early on from a prevention perspective, also incredibly important.
I'd love to see stats and data, put forward on the impacts of the use for those who are turning to cannabis as a maladaptive coping mechanisms for that developing brain. I'm going to turn to Jennifer from BC Children's Hospital. I'm wondering, Jennifer, if I may, do you have any stats on the mother's mental health of the young women you are treating?
And so when you say stats, do you mean in terms of the well-being generally?
Yeah, so do you see a correlation between mothers who suffer from anxiety, depression, or diagnosed mental illness and young women who are developing eating disorders?
What I really want to highlight is that we know that parents are actually the best resource for supporting their child. Parents are the ones who know their child best, and even parents who have their own mental health concerns, whether it's anxiety, depression, or their own eating disorder, can be the best support in one of our evidence-based approaches. So family-based treatments for eating disorders can be helpful regardless of what mental health concerns parents bring. At the same time, we know that having a child with an eating disorder is very stressful. And one of the factors that we talk about with families, it's the cliche of you need to put your own oxygen mask on in the plane before you can help a child. And so if parents' mental health concerns are interfering with their own ability to function, of course, this is going to have an impact on their ability to support their child with an eating disorder and other children in the family as well. We know that siblings can also be impacted when there's an eating disorder in the house, or when parents are not able to function well because of their mental health concerns.
So much. I guess the point I'm getting across is looking at investment in the mother. When we look at young women's mental health, when we have a mentally healthy mom, the chance of having a healthy child, that co-regulation, and I guess I don't know how much time I have left. None? Then I won't even ask my question.
Thanks so much. I'm now going to pass it over for 6 minutes to Mark Saray. Mark, you have the floor.
Merci, Madame. Thank you, Madam Chair. And thank you to all of the witnesses. We don't have a lot of time with 5 or 6 minutes, so I'll ask my first question to Mr. Rodrigue. Earlier, you talked about elementary school and high school, and others have mentioned the importance of working in these schools. There are bilateral agreements currently being negotiated between the federal government and the provinces, and the $4.5 billion that was mentioned. What recommendations do you have for the federal government? Because elementary schools and high schools are of provincial jurisdiction, and it is so important to reach these young people. So what role could the federal government play in assisting provinces to focus on these young people? Answer. Thank you for the question. I think it is important to properly define the role of the federal government. You could have a dedicated transfer for mental health. This is very important. We know that provinces are facing significant challenges with health, and often because of the stigmatization of mental health issues, when difficult choices need to be made for budgets, often mental health will be the aspect that is set aside. So I recommend that there be dedicated transfers for mental health to allow the provinces to determine what is needed for investments. I hope that investments in prevention at the elementary, high school, and post-secondary schools will be part of these priorities. Thank you. And we are trying to examine how to focus on these young people. Ms. Afifi, you talked about prevention and violence. You mentioned the lack of data as well. You took statistics from the United States. What are your recommendations for us as the federal government to enrich our conversations so that we have evidence-based funding, as you mentioned? How can we ensure that we have good data so that we target the work that needs to be done on mental health for young people specifically?
Thank you for the question. We have a great opportunity to collect data in Canada through Statistics Canada, and we don't take advantage of that. We have a lot of health surveys that are in place, some that are focused on children and children's health. We could very easily be putting indicators of violence into those and adverse experiences that children have into those surveys. We can also do them for adult surveys as well. This isn't a new thing to suggest. Statistics Canada does have some measures in some studies. but they're very limited. And then sometimes when the study comes up to run again, those measures are often the ones that are first to be pulled out. And it sometimes becomes a big conversation in why we need those in there. So we have the infrastructure in place to easily collect that data. We just need to understand the importance of it and recognize that countries all over the world collect very high quality data in a very safe way. And so Canada is behind in this, and we need to have more data in Canada so we can make evidence-based decision with Canadian data.
Good. Thank you very much. Sarah Canal, and thank you so much for the work you do, and Pat McDonald, the Sudbury Canadian Mental Health Association, and her team in Greater Sudbury do amazing work. And you mentioned about the 50% earmarked as a condition from the federal government to the provinces for community-based agencies. I wanted to ask, like, if we look at, we talked about decriminalization, we're looking at BC. We have an agreement with the province of BC. In Sudbury, for example, there's a safe consumption site that was just put on that was funded by the federal government and the city. The province did not want to fund. What happens when some provinces don't want to look at community base or some of the conditions or safe consumption sites, and what recommendations do you have with the federal government to deal with this?
Merci pour la question, Monsieur Serre.
Thank you for the question, Mr. Serre.
The reality is that there's community-based mental health and substance use health service delivery across the country right now. It's organizations like my colleague Abrars who are, creating service and meeting need because of the demand. The challenge is that these organizations operate on shoestring budgets and don't often have reliable funding from their provincial or territorial governments that allows them to scale up and expand service delivery to really meet that rising demand, and demand, frankly, that's been there pre-pandemic. So my recommendation to the federal government is to really collaborate with provinces and territories to identify those best practices, the organizations that have strong track records, and to bring those organizations into provincial and territorial funding mechanisms that often are there. We have great models in Ontario and British Columbia for funding community-based care. And regarding the issue of safe consumption, safe supply, these programs are popping up across the country. We know peer support buses in Winnipeg. There are great examples of work being done already. Police departments are great allies, paramedics. So just ally with those organizations that are already doing the work.
Excellent.
They're at the forefront.
Thank you so much, Sarah. We'll move back now to Adrienne. Adrienne, you have the floor for 6 minutes, sorry.
Merci, Madame la
Thank you, Madam Chair. I will try to go back and get some information from opening remarks. Mr. Rodrigue, you talked about gender paradoxes when we talk about suicide and suicide prevention. Could you give us more information on why we have such a paradox? Or Ms. Bartman as well, if you need to respond. Answer. The why of this paradox is difficult to explain. Mary?
And speak to that. I think it's fairly well established, the gender paradox in completed suicides and suicidal ideation. We know that young women, girls are more likely to experience symptoms of depression and anxiety, which are closely connected to suicidal ideation as well. Gender socialization clearly has something to do with why women and girls are more likely to have these expressions of distress. Men, boys have tended historically, and we've seen through the pandemic as well, to express those types of things with higher degree of problematic substance use. So we see those statistics come out over and over again, and unsurprisingly, women been more likely to express thoughts of suicide, and men to die by suicide. Access to means, knowledge about means, more concentrated amongst men than women. As Michelle mentioned, the importance of better understanding the experiences of women and girls is something on our agenda for next year. We just completed a study around men and mental health and suicide prevention, and we want to extend that to look further into the issues related to women. And we see gender roles playing a big part in all of this, as well as some of the issues that Sarah mentioned as well around how those shape people's agency in our society.
Merci beaucoup.
Thank you very much. Now, a question for Ms. Coelho. In your opening remarks, you talked about Australia, but are there other international work that could inspire our committee when we talk about mental health?
Thank you for the question. Absolutely. I think right now researchers in Canada look primarily to international colleagues. We know that eating disorders receive significantly less funding than many other mental health conditions, disproportionately in terms of the number of people who are affected as well. One of the factors that was highlighted in the eating disorder strategy is the existence of some costing reports, for example, that have been performed in the United States, in Australia, and the United Kingdom, which arguably is part of what provided the impetus for some of the changes in service models to understand the economic impact of eating disorders in order to then better plan services. And we don't yet have this type of study in Canada, although there are some national colleagues who have come together receiving funding from the Canadian Institutes of Health Research in order to start informing the economic impact of eating disorders.
Merci beaucoup.
Thank you. Ms. Mishmisha, you talked about how women are victims of hate, and if any of the other witnesses have anything to add, you are welcome to. Social media are a difficult environment to navigate, and they put pressure on women's image of themselves. So what would be the importance of legislating and working on this matter of hate speech online? What could this represent, a federal legislation?
Thank you so much for your question. A lot of work has been done to ask the federal government to move forward towards implementing any type of legislation to prevent the hate speech, especially on Facebook, on Instagram, and Twitter. Yet I don't think there has been any actions that taken in place. And speaking about also Bill 21, a lot of bill in our legislation do enforce that type of hate globally and nationally too. So I think, yes, I don't know what else to add, but I think, yes, we need action to be taken in terms of social media and absolutely in terms of our own legislation and our work environment, and also have more diverse representation for these population that we work with in terms of the, especially at the policy making level.
J'ai offert tout mon appui.
I offered all my support to Iranian women. I just returned from an international conference where we spoke in length about this matter. And what women talked about is the treatment that they faced, that a woman was killed for not wearing her headscarf properly. It is horrible that this can still occur in 2022. My turn is over, but all my support to Iranian women and their fight for equality and freedom.
Fantastic. Okay, Leah, you've got the floor. 6 minutes.
Thank you so much. Just very quickly, just want to follow up, and then I wanted to move on towards to Sarah Cannell after. You made a very good point about Bill 21, and what I've said was that it's about choice, right? Women's choice, what they want to wear, what they don't want to wear. It's about taking the ability to choose. I ask that because I feel like there is so there's growing Islamophobia in the country. I certainly worry about many women and young women in my riding who are experienced in Manitoba increased levels of Islamophobia. Would you say these kinds of debates that are taking away a woman's right to choose what to put on their body, even reproductive rights, we're having this whole debate about with Roe v. Wade, I mean, it's a time. Do you think this is impacting women's mental health?
Absolutely, because we don't feel that we are in control of our choice. Regardless what woman wants to wear, it's definitely her choice and not to wear. And I think also, like recently I've been reading the news in Switzerland. I think now they bought a ban of 10,000 euro something if you wear niqab in a workplace. I mean, at the end of the day, it's a woman's choice. And I think because we are still in a masculine society, we still have that men making these decisions for women not to wear or not wear. And I think that's mainly the reason behind it.
Yeah, thank you so much. Just want to talk about eating disorders. Jennifer Coho, you made a statement as well as Shalene Jones from Canadian Mental Health. So one of the things that we know contributes to like body distortion is the hypersexualization of young women and girls. We know that's an issue. I'm hearing very clearly from the witnesses today that that's just part of the equation, and I've heard very clearly that we need care, low barrier support. Sarah Cannell, you spoke about mental health supports in terms of income and time. I would say geographical in terms of as well. I'm wondering if the three of you could maybe speak about that. Low barrier care, not just focusing on one element that might be a factor causing eating disorders, and then access to care and what low barrier looks like. We'll start with you, Jennifer, and then we'll move quickly to Shalene and then to you, Sarah. Is that good? Thank you.
I've heard some of the fellow witnesses highlight options in terms of integrated youth hubs, which are something that exist across provinces in Canada, although not in all provinces. I think one of the aims of the early intervention work that I've highlighted of some of our international colleagues are taking the services outside of hospital-based services and trying to bring them to community and primary care. I'll hand it over to my fellow witnesses there.
Thanks, Jennifer. The issue of access is it's so critical, and one that I'm really passionate about. The work we've done here in Nova Scotia has been exactly on that, is looking at removing barriers to access for care for folks with eating disorders. And what we found to be working in our province is having a suite of low barrier, low intensity programs consistent with the sub-care model. So locally, we offer text-based chat, Zoom chats, peer support programs, including one-on-one mentoring, and groups led by professionals and groups led by peer supporters, as well as clinical support from therapists and dietitian. And we find this works really well in connecting with folks where they're at who may not be ready to access a therapist, but we want to catch them where they're at. And when they reach out for help, we want them to know that support is available and there's no wait lists. It's immediately accessible. No diagnosis required. So we've really tried to remove barriers. And we've had so much success with this here in Nova Scotia that we're now rolling out this peer support program nationally so that folks from across Canada can access a variety of peer support programs for that immediate and highly accessible support, and that we can then help them access more accelerated treatment should they need that.
Thanks. I would build on my colleagues' comments by adding consideration around the social determinants of health. So recognizing that in order for us to access care, we also need income supports and reliable, safe housing and food security. So just to add that often mental health concerns and problematic substance use intersect when we don't have those needs met. So in addition to ensuring we have access to care, it's also about providing those supports alongside.
I'm happy to hear you say that. One of the things that I've pushed for is a guaranteed livable basic income in addition to current and future government programs and support. And I've often said, especially around Indigenous peoples and First Nations communities, we're often pathologized. But, when you don't provide proper housing, it's bad for mental health. If you don't have clean drinking water, it's bad for mental health. If you don't have a toilet, it's bad for mental health. Oh, sorry.
It's all good.
Okay.
It's all good. Okay. Yeah, we're done. I got to watch Leah. She knows exactly. She knows with me, she can just usually inch out another minute or two. So here, we got to watch out there, lady. Okay, so we're now going to turn it to our next round. What we're going to be doing here is we'll be doing a 5 minutes, and then we'll go for 2 and 2, and then we'll come back for just a question from Wayne Long and a final question from Michelle. Yeah. Pardon me? Anita's going first, though. So I'm going to be passing it over. Anna, you have the floor for 5.
Thank you, Madam Chair. So my first question is to Abara. Did I pronounce that properly? Yes, close enough. Oh, okay. Well, thank you. So we all know that the IRGC is a terrorist group, and I attended a rally recently where I met a young woman from Iran, and I mistook her daughter as her sister. I was very appalled at her story. So she finally escaped Iran and came here with her daughter. She was 12 years old when she was forced into marriage. And her daughter was 12 years old. So we've got this young woman who's 24 with a 12-year-old daughter. She managed to escape, come to Canada, and she's still dealing with mental health issues of that whole process. Would you say that the $4.5 billion that was promised could help, when we talk about culture and culture-based situations, would you say that that money could help this mother and child, which I mistook for sisters?
Absolutely, especially if it's early intervention, like upon their arrival, right? So we at least prevent them from escalating and ending up in AR. That's first. Number 2, like direct support, absolutely. The other thing is also have more training to on culture competency and culture sensitivity to other care provider, because they are working on daily basis with these population, right? With these communities. So having that training to be, for example, we did provide a while ago a training for Kidshelp for their counselor how to work with newcomer youth and about in a culture sensitivity lens. So that was a great step. We want to see it more happening across other care provider.
Thank you for that. My next question, and I don't know if Jennifer or is it Tracy would help me with this. So last December, with the help of our local community, the Youth Corps decided to raise some money and funds and blankets and towels and equipment to go down and feed the homeless. This is a very shocking story, so I do apologize up front to anyone that's going to be upset by me sharing this story with you. And although these type of events are rewarding, it's also very depressing. So I came across a young boy who was 10 years old living on the streets. We talk about violence. Earlier it was said that parents are the best resources for children. And as much as I agree with that, I think sometimes that's not always the case. This young boy was in several different foster homes and kept escaping. And the only way to survive was for him to sell drugs from the local drug dealer so that he could afford the bare necessities of life. And it was very sad for me to see that. He is addicted. He admitted it. He's addicted to the drugs of choice. But he had no choice. He had no choice. How do we educate and help social workers to identify these situations so that we don't continue to have 10-year-olds living on the street? I don't know who wants to take that question.
I can just jump in for really quickly. So again, prevention of violence and adversity is key. If we could have prevented those early life experiences from happening, then this person may not have ended up trying to escape the foster care system. Child welfare also requires a huge reform in our country. Child welfare happens at the provincial levels across our country, and I do think we need a national approach to child welfare because I do think that it is failing our children, and having better supports for social workers and able to identify issues and support families to keep children intact with their families and support those families so that for better outcomes is ideal. And really, we should think of foster care as the very last resort.
And maybe I can add to that to highlight in the context of the past question when I was referring to parents, was referring to a question relating to mothers. And in fact, family-based therapy considers all caregivers. That might be grandparents, that might be a strong individual in that person's life who is not a parent, but who is there, an adult as a support person. And so family-based therapy can be effective with adults who are supporting, who aren't necessarily a biological parent.
Thank you. I'm actually just going to give this a chance for Arbar. If you want to, I know you've been trying to answer this question.
Since I work with a lot of group homes, so I want to add aside of revisiting the child welfare, we also need to listen to these kids because there is not much counseling and support, not in the school, also in the foster homes. And the first approach that they take is medication. And that's heartbreaking for children to be on medication for their mental disorders.
Awesome. Thank you so much. We're now going to turn it over for the next 5 minutes to Anita Vanderbilt. Anita, you have the floor.
Thank you very much, Chair. And my first question, I have a couple of questions. My first question is to Ms. Kennel, picking up on something that you said, and also the fact that what we're studying here will, in all likelihood, our recommendations will inform the new Canada Mental Health Transfer and how it should be structured in our negotiations with the provinces, which, as you know, are ongoing. And you really focused on that there's already transfers for acute care and that it really needs to be in the community. And you painted a very alarming picture about what happens to young girls navigating the system, where they have to be sick enough, they present at emergency, they're treated, I think you said because of the toxic masculinity, as if they're attention-seeking or manipulative or overly dramatic, which we know is a gender stereotype. They're given medication, they're sent home, and then there's no follow-up. So you mentioned some of the medication. There may be effects that might actually make their conditions worse, but nobody is following up in terms of modifying that medication, especially if they don't have a family doctor. That is a very alarming picture that you're portraying. And so I would like a little bit more about that recommendation that you made in terms of getting it out of acute care. We talked a lot in previous meetings about prevention and how, if the Canada Mental Health Transfer is going to be focused on community care, how you see that would be structured, and also how that would potentially interact and benefit with the other programs that we have.
Thank you very much for the question, Ms. Vandenbeld. What we're seeing is we know where the Canada Health Transfer goes, right? It goes from the provincial coffers or federal coffers into provincial budgets, and it ultimately gets spent on services deemed medically necessary. So that's hospital-based care, psychiatrists who are in the community, but again, you need a referral to get to a psychiatrist, and family doctors. So we know, sadly, that family doctors don't have the time and the training to be delivering comprehensive mental health and substance use health supports. So what we really want, or we see opportunity with the Canada Mental Health Transfer, is really to direct resources into the areas of the sector that have been underfunded, yet we know are so critically needed. So it's those wraparound supports that help people transition out of hospital if they've been in crisis care through either an emergency emergency department or a psychiatric ward, and really ensuring that they have the supports needed to advance along a recovery journey, whatever that looks like for them. And so it's not only the preventative upstream interventions that we see, but also that long-term ongoing support for people dealing with mental illness and substance use health concerns throughout the life course. So it's really ensuring people get the care that they need when they need it, wherever they are.
I appreciate that, and I think we'll note that for our recommendations. Thank you. My second question, and actually all of you mentioned a little bit about the impact that on the actual frontline workers, the impact on the people, and often they are also women. I wanted to ask the Mental Health Commission. Recently, you were in my riding, and out of our $50 million for trauma for PTSD of frontline and essential workers due to the trauma from the pandemic, we were able to get some funding for frontline long-term care workers. But more generally, what do you see, because I know that you were talking about particular programs like the Working Mind, where you can actually modify programs that can then be replicated across the country to help frontline workers, essential workers, who, as I think Ms. Cannell and others mentioned, are leaving the industry because of the trauma of this kind of work. Can you maybe elaborate a little bit on how that funding is having an impact, and then what you'd recommend going forward?
Well, I think there's two prongs to this. One is the better support for the mental health of the health workforce, including PSWs, right? Including people who work in long-term care, and the importance of attending to moral injury and psychological support for the comprehensive health workforce, really important. Secondly, we also need to pay attention to the mental health and substance use health workforce in and of itself, and make sure that really critical role that it has to play in improving access to high quality care isn't kind of overlooked and in the very important focus on the mental health of the broader health workforce. So both really important, and we can't improve equitable access to mental health services unless we have more people trained and able to provide those. So that's where that need for that comprehensive mental health workforce strategy is really important.
Perfect. Thank you so much. Now what we're going to do is we're going to change it up a little bit, because I'm going to be providing an extra about 90 seconds to the Bloc and DP, and then back for 2 minutes and 2 minutes, and then we'll be done. Okay? So Adrian, you have the floor for 90 seconds, a minute and a half.
Merci beaucoup.
Thank you very much, Madam Chair. Time flies, but I would like to come back to what's happening online and online hate and disinformation. I went to an international meeting recently where I talked about a better representation in Parliament. As an elected official, I brought my daughter with me, and I made a Facebook status to say, yes, it is possible to be a mother and work in politics. I received comments on Facebook that were criminal, that told me that it was criminal to bring my daughter there. I was told that an international summit was not the place for a child to be. I received horrible comments. And if we're talking about mental health, to have legislation to counter online hate will be essential. I have about 30 seconds if everyone wants to say why this matter is important in 2022.
Je pourrais commencer, Madame.
I can start, Ms. Larouche.
To you, and I think that as women around the room, politicians, you've all experienced this deeply and personally. My contribution to the conversation would be address the root cause, which is a lack of comprehensive sexuality education and mental health literacy starting in elementary school. That we need to address toxic masculinity and harmful gender stereotypes from the beginning.
Thanks so much. I'm going to now pass it over to Leah. Leah, you've got the floor.
Thank you so much. Just want to go back to prevention. I know that child welfare was mentioned, And we know that, for example, in Manitoba, 90% of kids in care are Indigenous. We have long-term historical examples, 60 Scoop, impacts on identity and sense of belonging. Child welfare is not the answer. Why is prevention so important in terms of keeping families together as a way to support positive mental health in young women and girls? Maybe Dr. Afifi, because I haven't had a chance.
Sure. Thank you for the question. Yes, I agree with you. I think that we need to it's easier to prevent a problem than it is to solve the many issues that happen after people are experiencing adversity, for example, trauma, racism. If we can try to prevent those things from happening in the first place, then we won't be having as many mental health problems to deal with. So we need to invest in prevention from the very beginning, and we need to be able to support families in order to understand how to raise children without violence, which includes not spanking their children. We need to provide supports for parents in terms of dealing with their own mental health so that they can be good supports for their children. And if it can't be a parent, as mentioned before, a caregiver, research has shown that if you have a supportive caregiver in someone's life, that makes a really big difference. It doesn't have to be a parent. It can be someone else in the family or another adult. So preventing problems before they're occurring, I think, is very important.
Thank you so much. We're now just going to go into our final couple questions. Michelle, 2 minutes, and then Anita, 2 minutes. Go ahead, Michelle.
We should have everything fixed by 5 today. It's fine. 2 minutes is tons of time. No, thank you again. And, coming back to the point of this study of the factors contributing to the decrease of young women's mental health, I think we need to absolutely focus on that. And I keep coming back to prevention is absolutely key, but at the same time, we're not going to prevent those who are already halfway through that. So we have to almost have a two-pronged strategy. I guess my question, I'm going to go back to Sarah, if it's okay, Sarah. If we are not taking care of these frontline workers, if we are not taking care of a mother who isn't aware of how to take care of her own mental health, that to me is the number one factor contributing to the success of a young child's mental health. It's the people around them, teachers, caregivers, coaches. If they are so exasperated by the stress of life or have never been taught the coping skills, what would the $4.5 billion do to help with that? Where would we see the biggest improvements to help parents and caregivers help their children?
I think that when we invest in upstream interventions and when we invest in mental health promotion and mental illness prevention, we know the benefits are long-term. We know that by supporting kids in school or post-secondary, mental health first aid, these are all part of a continuum of supports that we can provide that, support people in achieving the best possible outcome from themselves. And what I just want to make the point that, the investment on the table is not only, money out, but money back in. The return on investment when we invest in mental health and substance use health yields return on investment related to productivity, reduced acute care costs, reduced criminalizations and hospital stays. So just to say,
agreed, 100%.
Awesome. Thank you so much. And for the last 2 minutes, Anita, you have the floor.
I saw you nodding when I asked the previous question about the mental health and addictions healthcare workers themselves. So I'll just give the last minute for you to also answer that question.
Thanks very much. And I would echo what my colleague Mary Bartram has said around a national mental health workforce strategy. We need to be looking now for the long term in terms of what supports are needed to be put in place to ensure that we're not only sustaining the workers we have right now, who are predominantly social workers in community, but also planning for the long term. So whether it's that transition to virtual care that we're seeing on the rise, group-based therapies, these are all new innovations that we're seeing emerge predominantly out of the pandemic. So what can we be doing from a salary perspective, from a workplace benefits perspective, from institutional change perspective, regulatory issues? What can we be doing holistically to ensure that we're sustaining and then growing this workforce that's so critically needed? Thank you.
Thank you.
Thank you so much. And on behalf of the committee, I would really like to thank all of the witnesses here today. We have a very important study to do, so all of the information that you're bringing forward is very much appreciated. So just a reminder to the committee members, we need to have those human trafficking names in by the 28th, and anything else that you may need, just give us a contact. Everything looks good. Do I have a motion to adjourn? Yes, we do. Today's adjourned. Thank you.